diagnosis would have been. Because most of the people we make a diagnosis on these days, we don't feel anything in their prostate, or if we do, it's not some great big massive tumor. And maybe we should have got a clue from that, because a lot of those guys lived a long time. And I think that's the impression that I have learned over my career, is that most people who get prostate cancer live a long time, whether they're cured or whether they're not. Now, there certainly are exceptions. So the idea would be that you would make a diagnosis of cancer of the prostate, see if it's spread. If it hadn't spread, remove it or irradiate it. And then PSA came along about 1988, and in the early 1990s, people would do PSAs, and then if the PSA was elevated, they'd do a biopsy. So the number of people who were diagnosed with prostate cancer skyrocketed because so many more people were having a PSA. So then the idea would be, well, everybody said, well, goody, we're going to find all these people with prostate cancer, we're going to cure them, and we'll stop them from dying. And that led to a lot of what is now in retrospect considered overtreatment. About 30 years ago, which would be in the early 90s, which wouldn't be that long after PSA started, a fellow called Laurie Klotz from Toronto, a guy who has been in Cincinnati, although he's a Canadian, I didn't know him, but I have met him, he's been here. He and his friends were sitting around in the hospital cafeteria, and they said, well, why don't we just watch this? And in other words, they would get the lowest grade tumor and a low PSA, and they decided to watch it. And being as Laurie was well known, and he would start to publish this and talk about it, the wrath of the medical establishment came down on his head, saying that he would be responsible for deaths and he would have blood in his hands. So he was, like many people who start something, subject to a lot of difficulties, really, and he prevailed. And now everybody's doing what Laurie Klotz did in their way, trying to improve upon what he did. And what's difficult for me is I started doing this about the time Laurie started to talk about it. At that time, we could tell by the biopsy the grade of the tumor, the bad ones from the good ones. And we knew that the good ones would live longer, but we had no idea how long. So in the 90s, we treated everybody, basically. And then I was one of the first ones in this city to sort of say, let's try to just watch people. And that's called active surveillance. I don't know if you guys can see this, but this is his name here, Laurie Klotz, and it would be the lowest grade prostate cancer, recent characteristics. And we finally figured out that this is something that does not spread. Now, we didn't know that for a long time, but if it doesn't spread, you don't have to worry about it killing you, because it's not going to spread, and cancer causes death by spreading. And one of the proofs of that was a man in the old days when we would take out the prostate, we would take out the lymph nodes. Somebody got a group of 1,400 people with recent for fixed prostate cancer. They took out the lymph node and found no cancer in anybody's lymph node. So that was some proof to say that prostate cancer in the low grade hasn't spread, which made everybody feel better. Because patients, at least way back in the day, were thinking that they were going to, all of a sudden, that they were sitting on a volcano, that this thing was going to erupt and they were going to die from it. So there are certainly a lot of people who are on active surveillance who get cancer that has spread. But the impression is that there was a higher grade cancer in the prostate that was not sampled, and therefore the doctors didn't realize it, but they had missed the diagnosis. And when Laurie was here, Laurie Klotz was here, he said he was kind of on a quest. He's reached toward the end of his career, because he's done such a wonderful job with active surveillance, people are inviting him all over the world to talk about his experience. And he said he was sort of looking for anybody with recent centers for 6 cancer where the cancer actually spread. And he thought he might have at some point found one patient. So this sort of goes to the notion that we have identified something which is called cancer on the microscope, which doesn't spread, it doesn't kill people. And the way to manage it is called active surveillance. Can you move to the next one? Now, just to give another bit of background, there's something like 270,000 new cases of prostate cancer every year with 34,000 deaths. So it's about 1 out of 8 people who get prostate cancer die of the disease. I would imagine there would be more that would die, but if they didn't die of something else first. And one of the issues that comes up when you do studies of prostate cancer is why did the patient die? And I have this wonderful old patient who had a bad heart and was getting a heart problem and also had prostate cancer. You could sort of have a debate as to say whether he died from it. There can be competing causes. The most frequent time to get prostate cancer is in your 70s, and the most frequent time to die from prostate cancer is in your 80s. African Americans have more prostate cancer and die more frequently than Caucasians. Asians and Hispanics have less and die less frequently. And nowadays, the chances of a person coming to the doctor and the cancer's already spread is 7%. So it's, you know, when I went back to Michigan, we had lots of people coming in who had already spread it. And because you were bringing up the fact that we stopped doing PSAs, more people have come in with the cancer spread because we stopped doing PSAs than were coming in before that. So when there's so many men and doctors in our country don't do PSAs anymore, that has increased the number of people at the time of diagnosis with cancer already spread because of lack of PSA screening. Can you change the slide? So the most cancer of the prostate was in the 1990s. And since the 1990s, the mortality rate of prostate cancer has decreased by 50%. And so the idea is thought to be that, why is that? Half of it is thought to be due to PSA screening, and half is thought to be due to better treatment. Those are just guesses. Next one, please. Got to do another one. That didn't move. Now,
you guys want to turn a little bit, you see the full screen behind you. That helps anybody.
So who's eligible for active surveillance? People with recent patterns for fix, which is sometimes called grade group 2, and some people with the next grade after 3+4. But if you have a bad looking cancer, that's not recommended for
You got it. You got it.
No, it's not in it. It's not good.
That's not good.
Oh, okay.
All right.
So basically, active surveillance is for the good ones. Active treatment is for the bad ones. Next one, please. And when I first started trying to get men to do nothing, I found it was very, very difficult to ask a man who was diagnosed with cancer not to do anything. That actually took, 30 years ago, that was a hard sell. And then if you could finally convince the man, then you had to convince his wife. And then if you had to convince his wife, you had to convince his kids. And I said, I'm not going to screw around with your friends. You'll have to deal with your friends yourself. Because what would happen would be you get the family would go along with it, and then you go golfing. And his friends would say, well, why don't you just get your prostate removed, you're silly, so and so. And of course, skin cancer terrifies people. And I think that what I've just described to you in the last 10 minutes is really something that really doesn't act like cancer, doesn't spread, doesn't kill you. And people had asked to consider changing the word, because changing the word would make a big difference. And I think the other part of it is that doctors are in the business of doing something. I mean, you don't go to medical school to learn how not to do something when people get sick. I mean, so the whole approach to medicine is to do something. So, and if you're a young guy and you're trying to learn how to operate, or you're trying to learn how to do radiation well, you're not going to learn how to do that better if you don't do anything. You know, so there's the other barrier to active surveillance is the doctors would like to treat you. That's what they've spent all their years studying to treat you. Next one, please. Gotta do the next.
Yeah.
Okay. So the idea is, next one. The idea then is to find people with good prostate cancer, with low risk prostate cancer. And we look at the PSA, and nowadays, if I don't know how it happened with any of you when you were diagnosed, but if somebody has an elevated PSA today, the next thing is a prostate MRI. And if the prostate MRI shows something, then we biopsy that. If the prostate MRI doesn't show it, then we can avoid a biopsy. This is a way to avoid unnecessary biopsies, which we can do about 25% of the time. Next one, please. And then the other issue is, this is really all based on pathology. What does the pathologist, you know, the person that you'll never meet, that's the guy who reads your slides and sort of basically set your course. And so, how do they make a mistake? And so we want to have pathologists that are good at prostate cancer. I mean, they may be good at leukemia or something, but you want them to be good at prostate cancer. And sometimes it's not a bad idea. You get a second opinion on the slides. And then once you decide you're just going to watch it, the PSA, which is what you're watching, is being made by both benign and malignant parts of your prostate, because your prostate is just not malignant, there's a benign portion as well. And Tom Samey, a wonderful urologist, used to feel that PSA up to 9 was probably driven largely by the benign part of the prostate, not the malignant. So if somebody, we put them on this program, and so when I see somebody, I say, you don't need to do anything. You don't need any tests to see if the cancer is spread. You do need to think this over. And you do need to talk to your wife, and please bring your wife in, and let's talk to your wife, and then I'll let you guys deal with the children. And then the follow-up is a visual rectal examination, PSA every 6 or 12 months. And because people live such a long time, this is going to go on for decades, not just for a few weeks. It's the people that you get to know and get to like them in most of the time. And then if the prostate develops a lump that's new, or if the PSA goes up too high, you do an MRI and another biopsy and see if the cancer works. Is the grade now a grade that we feel the cancer is blocking? And you expect the PSA to gradually go up. And I think to me the thing was I had such a long practice that I would have people that I've been following for over 20 years. And nobody deals with what do you do for that person 20 years after active surveillance? You can't go to the literature and look up a series on how to deal with that. And then how high can you let the PSA go? And then, of course, people get old enough that they're not candidates for some kind of treatment anyway. But it's been kind of fun to realize that, first of all, that the patients live a long time, and that the prostate cancer doesn't cause any trouble over a long time. Next one, please. So the outcome of Dr. Klotz's active surveillance is a 99% 15-year survival. And nobody has survival data like that in any kind of cancer I know. But about half of the people during that period of time will have some kind of definitive treatment, either radiation or surgery. And in his experience, most of them had that treatment because they were too anxious. They couldn't just sit on the diagnosis of prostate cancer. I remember having a fellow who I just loved him. He was a retired fireman. And after about 8 years of watching it, I thought I needed this prostate. He said, "Oh, thank you, doctor. I was so worried about sitting on this thing, and I had thought I'd done a lousy job on making you feel comfortable watching this cancer." And so it's gone, and he feels better. Now, if you get the next group down, it's a little bit worse. The 3+4s have a 93% 15-year survival. And I just have to say that if you're looking at cancer as I did all my life, the idea of talking about 15-year survival is just not even on the board. The idea of talking about people living 99% or 93% of 15 years, insofar as the cancer goes, they might have died from something else. Their cancer didn't go in 15 years. It's just a remarkable thing. Next one, please. Now, just before this talk came out, an extremely important article from England that's come out of prostate cancer, published in the New England Journal of Medicine just this week. And it's something that we've been looking forward to for a long time. And what I don't think it is sold this way, but it's basically a prospective randomized controlled study on low-risk prostate cancer. And so they had about 550 men randomized to nothing, 550 roughly to surgery, and another 550 got radiation. And they had followed them on average for 15 years, and they had a 98% follow-up. So that's not a study we can do in our country. We're not good at getting a bunch of people together. We could do a study like that in Cincinnati with all of the doctors and patients that we have. We don't have a system where we can follow, that would cost a certain amount of money to get done. It would mean giving up the control of the patients to the study. It's the same thing, we had no data on COVID. I mean, when you were looking at what you could do for COVID, they were talking about the Israeli data or European data. But although we were treating millions of people with COVID, we didn't have our own data to know really. I mean, it's really a defect in our system. So what they found out was that after 15 years, 2.7% of the men with prostate cancer had died of prostate cancer. 21% had died from other things. But so there was 10 times as many people died of something else as died from prostate cancer in 15 years. And the main cause of death, I would have thought was heart attack, but it wasn't. It was cancer. I think about 30% died of cardiovascular disease and 50% died of other cancers in that 15-year period. But it sort of verifies what I've seen in my own practice is when you start somebody on active surveillance or on prostate cancer in general, most of them live a long time and don't die from prostate cancer, they die from something else. Next one, please. And then the cancer didn't spread very often. Patients that on active surveillance, who were followed 15 years, 9.4% of them, the cancer spread. If they had their prostate removed, it was 4.7%. If they had radiation, it was 5%. Now, some men whose cancer got bad enough they needed hormone deprivation therapy, 12% in the active surveillance, and 7% if they had radiation or surgery. And then the cancer got worse, so-called clinical progression. And the gist of this is that if you treated the patient in the radiation or surgery, the cancer didn't get worse as frequently as if you just watched it. However, the people lived just as long. That's one thing. So even though the cancer got worse, and there was some spread, and some worsening. People did not die from the cancer that had got worse, at least to a great extent. Next one, please. The next one, please. So, of the people who died from prostate cancer, the 2.7%, they were all about the same. The mortality rate, whether you treated the patient or not, was about the same as if you did, which I think was really quite striking to those. I think goes along with the notion that this really isn't much of a cancer. Next one, please. Now this gets into doctor talk. It's called prostate cancer survival. And at 15 years, if you just watch it, 97% of the people were alive with respect to the cancer. They didn't die from the cancer. If you had prostatectomy, 97% were still alive, and radiation therapy about the same. Next slide, please. I wanted to show you a kind of a thing that we see at medical meetings. This is a graph of prostate cancer specific survival in years. Now this is a 17-year plot. And you see that all these guys were still alive, going out. And when I usually see these kinds of things, the chemotherapy and other things, we're talking not 17 years, but 17 months, sometimes 17 weeks. And these plots just come down like that. So this is a remarkable thing for a cancer doctor to see something where the patients just go on and on and on. And then this one here. Can you bring that down a bit? And then the next one, please. Well, I can see the back. And this one is the chance of getting metastases. You see that the vast majority of these people don't get metastases, just a small amount, just a small number. So it's really, I think we stumbled on this. Lori Klotz stumbled on the notion we'll be able to try to do nothing, which was completely antithetical to anything that you'd ever learned in medical school, was to do nothing when somebody had cancer. And it turned out to be right. And now, with this study, we're actually getting a prospective randomized control trial to verify that. Could you give me the next one? Now, this also shows something where these are the people who got treatment. You know, if they were assigned to radiation or surgery, over 90% of people actually got the treatment they were assigned. But over time, the people who were out on active surveillance to start with, they ended up, about 61% ended up getting treatment at some point. So active surveillance in some ways is almost just like delayed treatment. But again, one of the main reasons for this was that the patient got nervous. I mean, obviously the cancer can get worse, but people just don't like that word cancer, and they want to do something about it. The last one, please. So I trained with a wonderful guy. I think there's one before that. Okay, this is fine. To the conclusions, let's do that. What is that? What does that say? Basically, active surveillance is something that Lori Klotz stumbled onto, which turned out to be right, which was hard to sell to patients to start with, and even harder to sell to doctors, which has turned out to be, you know, by just avoiding treatment, patients do better than if they get treated, as a general rule. However, it's not like you don't have cancer. The cancer does get worse. If you treat the cancer, you reduce the chances of the cancer getting worse. But even when the cancer gets worse, after 15 years, it doesn't kill you any more often than if you've had treatment. It doesn't kill you very much. So you have a dilemma where you can say, I won't be treated and I'll live with something that's going to get a bit worse. And I'm gonna be able to live with it for a long time. It's not gonna bother me very much, but I have to be able to live with that, or you can say, I don't want that. I don't want that cancer to be worse, I can have treatment. With the side effects of treatment, which are significant, I haven't really talked much about the side effects of treatment. And I'll have the last slide. So Dr. Whitmore, my old buddy, I trained with him at Memorial. And I've called this Whitmore's rule about prostate cancer, but I don't know if rule is the correct term. And Whit was wonderful with words and thinking. He said, it's cure possible. Then he said, it's cure necessary. Is cure necessary when it's possible? Is cure possible when it's necessary? And so I think that in some odd way sort of summarizes our fight against prostate cancer. And I guess you would say that with active surveillance, with some exceptions, we have pretty much found out that we can cure people, but it's not necessary. Now, the last thing is that although this is a wonderful bit of work that follows people for 15 years, men on active surveillance and men with prostate cancer live a lot longer than 15 years. And I think we just are at sea. We don't have real data. You end up having the doctor's experiences. What do you do with Tom, who, when did you get your prostate?
When I was 63, so it would be about 20, I'll be 84, 21 years ago.
So 21 years, what did it say if this PSA was up to 2?
Let me tell you what my biopsy said. 10% cancer in 1 core out of 12. 10% cancer, 1 core out of 12.
So you would have been
And I went to 4 different doctors. Every one of them said, oh, we gotta treat that. We gotta treat that. And I've been in potent ever since.
yeah. But see, we don't know what happens to really. If this PSA starts going. I've had people at 23 years whose PSA was unmeasurable at 15, died of cancer at 23, so there can be late recurrences. But one of the things I found is that the PSA goes up a bit and you're not sure what to do, and whether prostate gets a little harder and you're not sure what to do. But so we don't have scientific guideposts to recommend treatment, and we recognize if you're on 15, 20, 25 years. And I'll just end by talking about 3 patients, or maybe there's 2, right? My wife and I went to the Kroger on Saturday and got to know because our move is prostate. And I said, when was Jack's prostate? She said 1997. Jack, I think, was 44 or something. He is now, he made lots of money and he spent most of his time on his tractor. I guess his hair is light and doesn't have much of it. So there's a guy of 25 years and he's 70 years old and he's pretty healthy. We just don't know if this cancer starts to come back. The doctor basically has to use common sense, but no data on which to base treatment. Then my cousin, Bobby, in Minneapolis, his doctor felt a little lump in the prostate, his PSA was 8, he had at least a times for 7. And then he decided he wanted to go to the Mayo Clinic, and it's not very far away. And he had radiation therapy at the Mayo Clinic about 3 years ago. PSA has been unmeasurable, but his wife is demented, and they live in an apartment on top of a mall, and they used to walk in the mall and have a neat place to live. And for a while, Bobby would find that when he was walking with his wife, quickly around the mall, he'd get a sudden urge to urinate. And he'd have to run over to John and leave his wife in the middle of the mall, which was not what he thought was a good way to care for her. Then he started getting blood in the urine, and then he just got out of the Mayo Clinic he'd been there for 16 days because his bladder started to bleed, and he had a hell of a time getting the bleeding stopped. So he's been cured by radiation. But in him, the radiation was bad. And I don't know, you know, it's not like the fact that the bleeding stopped means it will never happen again. I mean, so, you know, you want to be Tom and impotent as a young man and afraid of the disease, or that guy in the tractor who's also, you know, or my cousin Bobby. Or do you want to take your chances with active surveillance, and if the disease gets a little bit worse, realize that the doctors don't really know what to do, and they'll use common sense. I mean, that's, so I think it's wonderful that we have such great long-term survival, but our patients love living the data. I guess is what I think it's a success story, but it's to be continued.
A while back, I read that America had twice as many biopsies as they do in Europe, and the survival rate's about the same. Is that still, has America cut down on the biopsies, or are they still pushing the heck out of them?
No, I think we've cut down. If you do MRI first, you can eliminate 25% of biopsies. And so that's not 50%, that's 25%. So if you were to come to the doctor today with an PSA, they would send you for an MRI, and if they couldn't send you an MRI, you wouldn't get a biopsy. So that's a start. But I mean, I don't know if any of you guys are interested in Bobby Kennedy's presidential run, but I listened to a speech that he made when he was announcing his candidacy last weekend. He said, we are the unhealthiest country in the world. That one of the reasons that Medicare expenses are so high is that everybody's overweight, hypertensive, and diabetic, and that we have more chronic diseases than we've ever had and than anybody else has had, which leads to big expenses. And so I think I'm not sure what the best thing to do is, but as I have got older, I'm less fearful of prostate cancer. I've had 3 really bad patients. By that I mean people who died within 2 or 3 years of diagnosis, so there's nothing they could do that would help them. All out of probably a couple thousand. So it would have been nice to help those guys, but the rest of them seemed a little long time. And so I think we really have to be sensible about what we're going to do about it. This treatment called focal therapy is sort of a departure from standard cancer treatment, where you look at the MRI and you say, this is the bad cancer, and we'll ignore the good cancer. So in other words, it sort of bases itself on active surveillance. It says, with active surveillance, you don't have to treat the low risk cancer. With focal therapy, we'll try to pick up the cancer that's bad and just treat it. And if you do that, the side effects of treatment are considerably less. However, you leave cancer behind. I mean, it's you know, there's a, but I think we should be less worried about prostate cancer. And if you do get it, you live a long time, almost for sure. And I thought it was wonderful to see the data that after 15 years, 2.7% of men died of prostate cancer, 21% died of other causes. Which, yes, sir.
For young physicians coming out of medical school, what do you see in the population in the sense of doctors recommending active surveillance versus?
I think it's getting to be much more standard of care. I think it's been standard of care for quite a while. But I do think you have to be aware of the conflict of interest that doctors have with practice. I mean, I invested my life in learning how to do treatment. So you have a bias to do what you've been taught to do. And I'm a surgeon, so I had a bias to surgery. And by the time I started doing active surveillance, I sort of got a lot of surgery on my system, really. I didn't have to feel I had to prove it to myself that I could do it properly. And we have residents to teach, and you have to teach them surgery, or. And the same with radiation therapy. You get paid more if you do surgery.
Yeah.
And so there's lots of conflicts of interest here, and and I think the poor patient who gets prostate cancer doesn't know any of this stuff, he is sort of stuck with. But I don't think it hurts to look around and get other opinions like Tom did. And you do the best you can, and I mean, you could have had access to some of this. Absolutely. You just didn't go for it. But it would have been harder to sell 21 years ago than it is today. But at the University of Cincinnati, I don't imagine you would ever get any treatment. Maybe other people, but those guys are pretty good, honest. There have been some people saying that if somebody we could get active students get active treatment that you could sue about. I don't know that much about that, but I mean, it's so in other words, it is a standard of care now to just walk.
Here's a question online. If the MR is negative and the tissue biopsy is not done, do you recommend getting a liquid biopsy?
No. A liquid biopsy is done if people have metastatic disease, the cancer spread, and you're trying to find out what type of treatment that you give someone with advanced disease. That if you were worried about biopsy, I'd get another prostate biopsy, but I don't think a liquid biopsy would help you.
I have a question. This popped in my head, and I don't know if you want to answer it. But I've heard, I'm the one with the urology group since 2017, Dr. Bill. There's youth hospital, and I heard great things about Christ. And I don't know, maybe even Good Sam or some others.
I think there's good doctors in all of them. I think Dr. Gelrith is excellent. I've never actually worked with him, but he has a very good reputation. There's a guy at Good Sam who, Eric Kuhn, has a very good reputation. We train the people at Christ. I know all of those guys over there. The people, I enjoyed being in an academic institution because you had to be on the cutting edge all the time. And so the guys at UC are always on the cutting edge. And Dr. Sadana is wonderful, and Dr. Paul. Dr. Paul trained with a guy who invented robotic prostatectomy. So I put a lot of stock in the fact that you actually trained with a guy who invented the procedure. And Dr. Sadana is the smartest son of a bitch. I didn't say that out loud, but he is really smart and he's very driven. And there's a lot of interesting research going on in prostate cancer. And he's now trying to develop this field in Cincinnati of focal therapy. And I think it's probably premature to say it's standard of care, but it certainly is trying to make a name for itself to treat the bad cancer and limit the side effects of the treatment that we have with radiation or surgery to the prostate. But he's a very smart guy and a very good doctor.
Has he done hundreds of?
What's that?
Has he done hundreds of laparoscopic?
Oh, sure, yeah. The young doctors have never done the open surgery. I wouldn't want to do it. So if you get a guy less than 40 now, and you want him to make a decision to take your prostate out, they'll probably say, I can't do that. I've not done enough. So the young doctors have had a lot of bias. And because that's his field, he's not funding them. And I'm sure he hasn't done as many as Mark Elwood. Mark Elwood's been doing it. We've had a robot in Cincinnati since 2004. We got one at UC and they got one at Good Sam at about the same time in 2004. So it's been around for 20 years now. It started in Detroit in the year 2000. And, but the young doctors, that's all they do is robotic surgery.
Dr. Delworth does robotic surgery, it doesn't work.
Yeah. No, I mean, Mark's been doing it there more or less since it started. As I understand it, the first robot they got was a Good Sam, and he did some work at Good Sam. And then when they got one, Bethesda North, which was his main bailiwick, he started doing one there. And, you know, we all taught ourselves how to do robotic surgery. It wasn't a whole bunch of people to tell us, you know, so it was a little bit, we had to learn how the hard way. But there were lots of cases in those days because we were treating everybody, you know, and so there's many fewer candidates for prostate surgery now than there used to be. Because of active surveillance and because of focal therapy. But I think if you're with North Dallas, we probably could be
We're clearly number one in the city in the number of cases, and Elmer Kuhn, which is his partner, urology group, and he's not a lot too.
And so does Dr. Paul, and so had I in my day. You know, so has Dr. Sedana. I mean, I don't know how many hundreds you have to do before. You know, I mean, whether you do 500 or 1,000, does it make any real difference? It's interesting that any of this business of how many can be done seems to come up in prostate cancer. But nobody ever asked how many hernias you've done or how many heart operations. I mean, you know, in other words, it's an interesting thing that people worry about how many prostate operations you've done, but if you want to pick up a bladder, which is a lot of that, which you're going to ask how many those you've done.
You can't throw that anyway.
Right.
The doctor tell you where he wants to just let us come in there, let the spot, he didn't trust it. Then what they're doing.
But I think looks good. I think that's Dr. Kuhn is good, and I think the guys at the university are very good. I would tend to think that if it comes to the cutting edge, you know, because these fields move, they're constantly moving, they're constantly changing. And the people who keep up with that, you know, it's the job of the university people to be on the cutting edge. I don't know that you have to be on the cutting edge. You know, most of the things we do aren't on the cutting edge, but I prefer the cutting edge doctors. Let me put it that way. But those other guys are very good doctors.
I wonder regarding the question of how many hospitals have we done with people. I tend to think maybe it's because there are so many stories in the world about the terrible side effects. Some people can't even leave their house because they have no control of the urination, and even worse on the rectal side.
It was a measurement made by, I mean, doctors compete against one another. And so a lot of the best doctors in the country would like you to send all your patients to them. So they would start to say, it depends on how many you've done. But I'm an old surgeon and I'm a good surgeon, and I knew damn well that was really not true, because if you were a lousy surgeon and you did more cases, you were still a lousy surgeon. But the lousy surgeon, you know, the pain surgeons. And one of the things that's really interesting is the odd guy comes along, and without any training or background is a natural. And I had no idea how you would be a natural. You know, the rest of us had to learn how to get to the point that these guys almost start up at. They just can see it, they can do it. The eye-hand coordination, and so I think I've trained probably 2 or maybe 3 really good natural surgeons. And if we started doing the surgery in the second year of their residency, they were guys who didn't need to finish the residency. They could have gone out without it, but most of us are human, and we have to learn with practice. And So that's this notion that, I mean, I've heard people say that if you haven't done this 3,000 robotic prostatectomy, you should really, and that's just bullshit, you know, that's just a marketing ploy. I mean, what was your occupation? But I mean, it would be like saying, how many bridges have you built? You know, I mean, I don't know, but maybe that is a measure that's important. But, yeah, I happen to think that's a marketing ploy.
What about the term nerve sparing?
Well,
What a question.
was
I say it because I have two brothers who live in different places, we both have the same doctor who was at Northwest University. And he had a reputation that he was very good at nerves.
Bill Kelly.
I don't think it's that before. Now, one guy doesn't get good on.
Well, when the guy who invented that was trying to deal with the fact that most people with surgery became impotent afterwards. And he discovered the reason for that was that there are nerves that go on the outer coats of the prostate. So that if this is the nerve that goes to the penis, and the prostate is kind of like my jacket, and so the nerve goes in the outer coats of the prostate. And so if a man gets sexually aroused in his brain, the impulses go to the penis through those nerves, and if you cut them, then it's not going to work. So Dr. Walsh learned where these nerves were and how to preserve them. And he also had a very select practice where he would have a lot of young guys who were still sexually active who didn't have bad cancers. He treated the kind of cancers I was talking about tonight that we don't treat anymore because they don't do anything. So Pat made his living and his reputation on sparing nerves in people who didn't need any treatment in retrospect anyway. And I think it probably was a little harder to preserve these nerves than it would be just to take out the whole prostate. Now, even Dr. Walsh did not think you should do that unless you were young and unless you were sexually active and unless you didn't have a bad cancer. But he felt that the bad cancers would go through these layers and spare the nerves and spare the cancer. And I've often wondered how many men have had their cancer spared in an effort to spare their nerves, because Pat had. It's interesting with guys like him and Bill Catalona, they had a wonderful reputation of nerve sparers, so they got the best cancers and the healthiest people. Most of the time, the good surgeons get the worst cancers and the least healthy people. That's kind of the way it works. You know, they send all the trainer to the university, and all the healthy guys stay at Bethesda North. I mean, I'm being a little bit facetious, but only just a little. Places like the University of Cincinnati and other institutions like universities get the cases that other people really don't want to look after. I don't know where I was going with that, but so I don't know. How old were your brothers when they had their surgery?
They were young.
Okay, the 50s. Well, then maybe nerve sparing was reasonable.
I think neither of them one of them. He never got story. The other one, he told me he didn't have much trouble with the side effects. He died or something else.
Yeah. But I think lots of times the nerve sparing didn't work. A lot of people wanted to go to those doctors to spare their nerves. I often thought that was just another, thing to put into the mix that I think almost confused people. I spared some nerves and I kept my mates. I made with some men to be potent. Probably more of them were impotent when I spared the nerves, and so But I think that's where this notion of how many have you done came from. They came from people like Dr. Walsh, who were really trying to attract more business, I think, really.
I don't know this. How common is like radiation? People talk about urinary incontinence that we can see. How common is damage to the rectum? I never heard much about it. And I know
Well, a man gets a prostate exam, you put your finger in the rectum, and so the rectum is immediately behind the prostate. And it's just millimeters away. And so if you radiate the prostate for sure, you have to radiate the front wall of the rectum. And so everybody's rectum gets radiated, and the majority of people seem to be able to get along fairly well that way, except guys like my cousin. You know, and as I understand radiation, and I don't want to put words in anybody's mouth, over the years they have decided they want to give as much radiation as the patient can tolerate. And so they sort of accept a 5% or 3% significant complication rate. So they'll radiate people with doses that may harm 3% and the other 97%. It's actually quite cold-blooded. But there are people who can't tolerate the radiation in the scan, and the rectum's right in the way, the bladder's right in the way, and so my cousin got the bladder effects of the radiation, but I hope he doesn't get the rectal ones as well, because he could. I mean, that may be something coming down the line for him, that he'll start reading from his rectum neck, you know, so I think I have a great I'm not a fan of radiation because of the complications like my cousin is having, and the other thing to remember is radiation causes cancer, and so I've dealt with radiation-induced prostate cancer, radiation-induced bladder cancers, radiation-induced rectal cancer. So somebody gets cured of their prostate cancer, you know, they have another really bad cancer to deal with. So, and that's something that does happen. I mean, there's a woman in Cincinnati who sponsors a cancer survivor group. And I think when she was a young woman, she had some kind of lymphoma and she had to have mammoth radiation at her neck for the lymph nodes, which cured her. But then as she got older, she ended up with breast cancer in her breast because of the radiation that she got. So, I mean, it's not just, and not everybody with radiation gets cancer, but some do. And, you know, I just think it's, you know, surgery at least doesn't, it causes lots of problems, but it doesn't cause cancer. You know? Yeah, but it's a form of radiation, sure. But yeah, I mean, it's radiation, and from the. I mean, I think we first figured this out with Nagasaki and, Hiroshima, the people who were not killed with the blast, they would have instances of cancer as they come over, which has been very, very thoroughly studied by people that had to do with the amount of radiation that they got, which depended on how far they were from the epicenter. I think the same happened in Chernobyl. Radiation causes cancer and therapeutic radiation, which is what we're talking about, causing cancer too. And I think especially in prostate cancer where you're living all the time, you get a longer opportunity that if you're unlucky and those cells were altered, that you could get cancer. So one reason I would check men with your rectal exams on men and radiation was I was not so worried about their prostate, but did they have a cancer in the rectum? Did they have and you can even get cancers of the prostate that are different than the one that was originally treated. I don't know how often it happened. We were at the bottom of the funnel where you see, and I would see a fair number of radiation-induced tumors from pelvic radiation. But nobody will ever put a figure on how frequently does that happen.
Dr. Delworth seems to be, I get the feeling he's anticipating that my gleason 6 will go to gleason 7, presenting the cells will become more abnormal. I don't know if he's really anticipating that.
Who is this?
Dr. Delaware.
Oh, he thinks it's, yeah,
I get the feeling he thinks it's gonna get it become at least in 7, which doesn't that mean that some of the side will get more ugly or?
yeah, that's what it means. You know, after you've had a form of treatment, then the Gleason scores are not as accurate because the tumor cells have been altered by radiation. They look different under the microscope. So the actual rules of creating prostate cancers, you're not supposed to use the Gleason score after radiation therapy because of that.
Yeah,
When was your radioactive student plan?
no, I didn't have that.
Oh,
A friend did. I thought about it. Close friend from school.
yeah.
Had the seeds. I haven't had anything come back with surveillance.
Okay.
I've had 2 biopsies.
Well, you know,
A lot of MRIs.
I knew the guy who started the island, his name was Urologic. He was a Danish urologist who had trained in Canada and was in the equivalent of a hospital in Seattle, kind of like Bethesda North. It was out in the suburbs. And we went out to learn how to do it. And I said to him, Hawken, what are you going to do if this doesn't work? He says, I'm going back to Finland. I mean, that was the furniture. But this guy didn't.
Did that happen often? You have a basic space and
No. I don't think that methods are changing. What I think is the usual explanation, if you have another biopsy and you have a recent clinical study, that means that that cancer was there all along and simply not biopsy on the first biopsy. Am I making myself clear?
And then you get that area.
Yeah, I mean, you know, the biopsy is based on setting. So if you hit that on part of the prostate, you could have a, you know, so I would say that you had a setting at some point in time.
You know this.
That it was there all along. And that is sort of that's sort of one of the potential problems with prostate surveillance. Because the doctors get adequate samples of your prostate. And I think the answer is most of the time they do, but with instances when they might not.
Yeah, the second one was using an MRI for it.
Yeah. But I mean, you know, but you can miss cancer of the prostate. And you know, there's no lump or anything like that you can be sure to get the lump. But I wouldn't obsess about it. I mean, you know, you saw the numbers there. I mean, you've been with forever and back to someone else. I mean, you're worth the shoot. I mean, I'm very encouraged by the fact that after 15 years, the death rate is 21%. So that means 79% of those guys were alive 50 on an average of 15 years afterwards. And that's I thought that was in some ways in that study I showed the best message was that people were alive.
I've been pretty relaxed about it. Since I got that first one. And what my thinking is now, I've seen so many people do well, if it's outside the gland with hormone therapy and radiation, that I really don't have, I can take the risk to get just living happily until it goes out of the gland. And be like one of those people who've got hormone therapy and radiation who are doing so well.
Well, that's what happened to my cousin. He went to that clinic and he's just got out of the hospital after being there for 16 days from bleeding. So, I mean, you know, you can't blame them. I mean, I would imagine they have radiation therapists would be on fire. They're supposed to, you know. And I think it's a technique, and then hormone therapy. I mean, you're a very masculine looking guy. I mean, be personal, but so if you take hormone deprivation, this would be the devil's advocate. You won't get any more erections. If you have any now, you won't get any more. You'll get hot flashes. Your skin will change to be more feminine. Your genitalia will get smaller. Your bones will get weaker, you'll get fatter,
Nice.
and your heart won't work so well. And for apart from that, you'll be fine.
Make it rest.
It's funny, yes, yes. What question?
Yeah. So I personally, one of my goals for my patients was to try my best to avoid them needing hormone therapy, even if they needed it, they needed it. I mean, I think those are significant problems, and it seemed to affect the vigorous men more than the sedentary ones. You know, the guy who was, you know, not running and biking all the time was the one who found that he wouldn't have the stamina or the strength, as opposed to the fellow who was, you know, watching, you know, the soap operas all day, and didn't seem to bother him as much. But I mean, I think it's you know, so I would go for surgery simply because if you need it, I hope you don't need it, but if you've got a good surgeon now, you probably do a good job. You'll be laid up for a month or something, not terribly badly, but a month. You'll probably have some urinary leakage that will probably dry up within a few weeks or a few months. You'll be back to normal. You won't have to worry about radiation damage to your rectum or your bladder. You won't have to worry about the effects of hormones on your body. I mean, hormones used to be, when I was switched, I was trying how we were initially. So we would see a lot of guys with advanced prostate cancer, metastatic cancer, and we would treat them with hormone deprivation. The average life expectancy would be 2.5 years. And over 2.5 years, in older men who had advanced cancer, we didn't really see the effects of hormone deprivation that bad, and they were sick from them. But now, I mean, somebody like you might be on hormone deprivation for 15 or 20 years. I mean, that's a different ballgame.
Yeah. Not so good. Not so helped up without hormone therapy.
No, but I wouldn't do that either. Just
Surgery.
but don't do anything, would be the best.
Yeah. I guess I'll wait for Dr. Dellers. Insist.
Yeah,
When he retires, you retire.
yeah, I don't know how old Mark is, how old is he, 60?
It's close to 60.
Yeah. He's a